Bom dia a todos.
Good morning, everyone. Welcome to the second day of our event. Let me confirm if you can see the projection. Is the transmission on? Good morning, everyone. For the ones present here with us and the one following us from AI YouTube channel. Let's start reviewing what we talked about yesterday. It was such a productive day, and we were a bit tired the last of yesterday at the end. So today we will review what we talked about yesterday afternoon. Let me introduce myself. I'm Patricia Soares from the Preventive Medicine Department in USP Medical School. It's so difficult to summary what they talked about yesterday. Professor Rija, Maria, Roger. Thinking on Professor Rija's lecture, Normativity in AGTA, Ontological, Moral, and Epistemological Commitments, she talked about AGTA's main goal, orient the decision-making process in adopting new technologies, considering context and values may vary from place to place. And this influences what the definition of value and established priorities. So she talked about value in health a lot. We try to assess this by AGTA processes, and value depends on context and perspective used in the assessments. AGTA, she said, AGTA may be used in different phases in technology life cycle. And this lens we have been using in this event about AGTA along the technology life cycle, the LC framework. This new approach, we are talking about it here. So LC framework assessment, they are influenced by the different stakeholders, the 7 Ps, patient, population, payers, policymakers, providers. She talked about ethics. Ethics is present in every step of AGTA. She talks about all of them. And we need to remember some basic questions. Should we use this technology? Why? So these questions are fundamental before triggering the processes of HTA. And we should list the criteria used in order to assess value of such technology for the health system. And different societies may have different opinions on the interventions, and they are influenced by value, cultural values, I mean. So she talked about cochlear implant. For that country, for that moment, the policymakers thought important, but the community, the impaired hearing people didn't think it important. They had a different opinion. So Professor Reed also talked about the challenges precision oncology technology bring for the existing norms, both in research and healthcare. They change the disease course, patient survival. There is the value for hope. And they have higher costs. And there's also the adverse events that weren't considered with other technologies. So how should we balance the additional benefits, the increase of survival, but having, on the other hand, high cost and adverse events? She also pinpointed the processes, the promises of precision medicine technology, and what is actually delivered after these technologies deployment. So what was proposed beyond the clinical trials was the real-world evidence. And she finishes talking about ATS involving ontological, moral, and epistemological commitments. And they influence how evidence and values are incorporated in decision-making processes in HTA, in health technologies, I mean. So what evidences and values are incorporated in the decision-making processes on health technologies? These were the bullet points in her presentation, and this will be present in our channel, our AI channel. And our EETOP group will talk about products. There are technical products in order to publicize them for the society. We will talk about the individual lectures so that we can communicate beyond the academic community, so that we can translate this knowledge production and share it with the community in a way they can understand it. Afterwards, Professor Mariana Novaes talked about HTA, LC-HTA framework. Professor Novaes talked about the involved stakeholders, population, individuals, sick people, education and research systems, the industry. She talked about innovation, development, and production of new health technologies. She talked about public bodies and regulatory authorities. And all these stakeholders working together in precision oncology ecosystem, they are influenced by social, economic, political, and environmental dimensions, which are specific for every country. She talked about the differences in stakeholders' positions, considering the two models of economical production, one chemistry-based and another precision medicine biomolecule-based. HTA studies that we have been conducting so far, they were designed for the previous model, which was the chemistry-based one. These normatives of HTA studies, for that, we need to think of another model, another design, study designs that would encompass the biomolecule-based studies of precision medicine. She also talked about individualization, precision, relationship, and the technology mass production. We were used to develop studies for this mass production. And there is a complexity in using these personalized innovations and use it for mass scale. This is complex. She also talked about the paradigm shift in equitative innovation, and she talked about the need of enhance and diversify the stakeholders involved in this decision-making process. And it's also necessary to have a continuous assessment in LCT HTA. And she ends up talking about the sceneries where we are going to use LCT HTA framework. And this is recommended in some scenarios, such as scenarios where we have limited evidence, we are not sure about the clinical benefits in using these technologies in our clinical practice. When technology changes a long life cycle, when the learning curve in using this technology changes its results, and when a context in healthcare is impacted and also impacts the use of such technologies. So pay attention on these scenarios where we can apply LCT HTA. They are applied for precision oncology for sure. Afterwards, we have Professor Roger Chama's talk. She talked about precision oncology, benefits and challenges for the health system. She talked about the Center of Studies and Convergent Technologies for Precision Oncology creation, which is Comprehensive Center for Precision Oncology called C2PO. This C2PO is a place where there's education for our grad students. And then we can develop a look for social impact and economical impact beyond our scientific impact of our knowledge production. She talked about the challenge of implementing precision oncology in our public health system. And he also highlighted that in precision oncology in our public health system, we need to have a better diagnosis which are made in real time. This diagnosis needs to be more accurate for patients in the Brazilian public system. Maybe not for every patient, but for some patients in a specific moment during their health care. He also highlighted about the need of real-world studies. This is important to spot the benefits of precision oncology treatments and to develop these platforms of database, data collection, information production, and evidence to retrofeed these studies that will be done alongside LC. The research centers and education centers needs a support both from the public and private sector because the costs are very high. Later, we had the lecture of Dr. Ana Carolina de Freitas Lopes. She is coordinator of the monitoring area of Conitec. She presented assessment of health technologies in precision oncology. She talked about Conitec's work. She talked about matters imposed by oncology, especially high prices and the unsure benefits of such medicine for patients. She talked about the high cost, the high entry cost of medicine, and this has been made the access of patients difficult. And she has been following this high cost of entry of such medicine. She also talked about acquisition, which is mostly decentralized in oncology in our public system, and this makes a high cost and makes negotiation difficult when buying these products are decentralized, and prices are more expensive when such a process is done. She talked about how difficult it is for patients to have treatments that are already incorporated in our public health system. The medicine approved by Conitec do not reach the number of people estimated in the studies. She provided examples of about 7 years range of time necessary to reach the people estimated to be reached by this medicine. She talked about the insufficient infrastructure for molecular and genomic tests and the approval of the Cancer Control Prevention National Policy. This policy has the goal of mitigate the limitations and reduce the inequities in cancer treatment in Brazil. Dr. Alitan Jr. talked about NGS. He talked about AGTA in precision oncology. He talked about NGS as an alternative to preliminary methods of DNA sequencing. In the literature, there aren't evidences of clinical benefit because the studies are accomplished in a way, there's no comparison groups and they do not assess clinical outcome. And there isn't any standardization in AGTA studies in order to assess NGS. And he talked about some possibilities to assess such technologies. First of all, using real-world data, using studies that assess important outcomes for oncology, increase of disease-free survival, overall survival. These are important outcomes. And he talks about new ways of payment, for example, payment by result. The last talk was Professor Wanderson Rocha from the medical school. He talked about clinical trials design for precision oncology, generating robust evidence, patient selection, results, and cost effectiveness. He talked about CAR T-cell treatment, which is recommended for acute lymphocytic leukemia, non-Hodgkin lymphoma, and multiple myeloma. He talks about the therapy cost, which is between 2 to 3 million of reais for only one infusion of the product. And this cost doesn't include hospital bills. In Brazil, there's an estimate that 4,000 patients per year would benefit from the use of these therapies. So he problematized the impact in the budget to treat these 4,000 patients, where only the product cost 2 to 3 million. And in the occurrence of these high prices, he said in some European countries, for example, Spain, they have been investing in the production of these CAR T cells in public labs from these countries. And this model has been used here in Brazil. He talked about the experience in the two advanced therapy centers, Nuterra São Paulo and Nuterra Ribeirão Preto. These labs have been recently implemented, and they have been using CAR T cell production, and this can reduce cost 10% for the price actually made. And he also talked about the few alternatives existing in the Brazilian health system to treat multiple myeloma. And he said that the treatment with CAR T cells may be of advantage, even with this value, because it can avoid the intermediate treatments which have high costs. And we had a whole discussion with the regulatory agency, and this was done by Gustavo Lins. So this was our warm-up. These were the highlights of yesterday's conversations, and I would like to invite for today's session Dr. Caterini Abrali, CEO, the Leukemia and Brazilian Lymphoma and Leukemia Society.
Dr. Caterine Moura da Fonseca Pinto, who is Executive Director from Abrali. Welcome. I would like to invite Dr. Joyce Valentin, Global ATA Strategy Lead at Roche, and PhD Alessandro, who is going to moderate this panel. The objective in this first event was to put these stakeholders together for precision oncology to start discussing all these challenges of the implementation of these and its practical applications at SUS. And today we have academia, researchers, producers, manufacturers, regulation bodies, representatives of health assessment centers. And today we start with members of representatives of patient associations and the corporations that are here. So first I would like to invite Dr. Caterini to be here. Good morning. Are you fine? Are you excited? Good. Beforehand, I would like to thank so much Patricia for this opportunity. This is an amazing time. I'm very honored to be part of this event, and I'm very glad to be contributing with this group. And it's very emotional to be here at USP, especially at this place, because it brings me great memories. Not a simple homework, my speech today, my lecture. My homework is to bring, actually, my task is to bring the perspective of patients and debate about the value generation, the social value of health service, and doing this specifically under the perspective of the eye of the patient community, because there's a temptation to give my opinion as a doctor, as a medical professional. But yesterday we've had all the opportunities and they were so rich. The presentations were amazing. It was great to listen to the insights and contributions for the various stakeholders. So today we're going to go on with another view. And I ask you, those who are here, to exercise this so that we can touch what is social value of these technologies in health, in precision oncology, through the eyes of the benefited people, the users who are going to have their lives impacted by these technologies and by decision making of their incorporation or not. I'm going to bring an overview from where my speech comes from. I had an association that is been dedicating for 2 decades in hematology and oncology. We seek to support patients and family members who are in a journey against cancer and promote improvements regarding their access to the healthcare system so that there's equality in the treatment for cancer. My place represents a community of patients that we keep in touch, very close contact by following their journey. And this happens in a very structured way. So this is where we talk from, by representing this community of patients. And we do this in Brazil from a national point of view, but we also represent Latin America. So we have the opportunity to listen to the experience of other countries. Among their challenges, we have this one, the incorporation of new technologies. And we also have a place in various global spaces internationally that have been discussing best methodologies and models of technology assessment. So we are somehow following closely this scenario that is challenging not only in Brazil. Our our performance is focused in 4 pillars, and I would like to highlight 2 of them. We believe in the participation of the society and patients in a structured way, qualifiedly and evidence-based in the real-world data, so that we can contribute positively with the challenge of the health system. That's why we have a research area of monitoring, which is called the Oncology Observatory, and we develop various quantitative and qualitative research with data in general, but also with primary data from the patients. So from the real life experience of the patients, we make up a database that is important so that we can have evidence to qualify our participation in this scenario. Second point is that we advocate as representatives, and we have comprehensive participation within SUS. We have seats in the councils, the health councils at 3 levels, and we participate actively at CONITEC and National Agency of Health in Brazil, so that we can have this bridge. This is our biggest commitment for this patient association, to bridge, explain, and educate the society and train the society on the challenges we face with the health system and how this impacts in the process of delivery of services to patients. So we are very close, and we have various links with patients during their different phases of their care journey. Yesterday, everything that is important has been said yesterday. Yesterday we saw clearly why this is a relevant point with a social impact. I would like to highlight, though, that our colleague who talked about technological transition and the advancement of cases of cancer in Brazil, we have a study that has been updated and has been carried out by the Oncology Observatory. That is the first case of mortality in various municipalities in Brazil. We all know that this is a subject that is relevant, and from the point of view of sustainability, as well as with the impact to the population. I've brought some highlights. I'm not going to go through all of them, but it's extremely important that we understand the regulatory milestones and the critical aspects of HTA. So we have to go simply but focused and explaining how this impacts on decision making for the whole society. We have to make a broader debate socially so that it reaches the population in a way that disengages patients from the moment of their discussions on prioritizing the development of research nationally, where we invest public resources in the development of new therapies, until the end of the cycle with the incorporation and availability of these treatments. So if we don't go through this debate in a comprehensive way, we're not going to have the level of understanding of the population on our decision making in HTA. We have to promote a balance within SUS between the control of public expense, allocation of resources, efficiency, prioritization of public policies, but we can't reduce the access to this. We have to keep the focus on equity. We have huge promoters of inequity in Brazil. We have factors that promote impact in our society, and we are not supposed to cause other inequity actions. So from the point of view of patients associations, we have a responsibility of educating and taking accessible training and qualification. The opportunity of improving from the point of view of HTA, what calls my attention, what gets my attention when I talk everywhere in Brazil, when I talk to specialists in other countries and here too, is that we have to align. We feel at times that we have no alignment between those who are thinking policies, who are developing technologies, and who is investing in technical and scientific development with the technical capacity to deliver the result expected from by the population. About social value, to emphasize for those who sometimes forget, those who are in other countries who have a distinct scenario. Health in our country is a social right, just like the participation of the society in the design, elaboration, and implementation of public policies. So we can't forget that. We have a health system that dares to be universal, and we struggle to offer comprehensive health care everywhere in the country. And we have many barriers, and this comprises inequity. And we have a history of inequity. Access is not only about access to therapies and new drugs, or not to innovative drugs. Sorry, I'm confusing the languages. I'm coming from another event. So the access is not only about drugs and medication. We're not being able to offer medication that is incorporated together with care with conventional therapies to treat cancer everywhere in the country, let alone the innovative therapies. And then the cost effectiveness assessment and the process of assessments shall not be disaggregated of the concept of value generation. So the question we have to face is value to whom? The value in health has many approaches, and the first one is to improve the health of the population. This is the same idea among the stakeholders. But the value in health is only one thing. Is for the patient and shall be directed to the benefits allowed to the patient. And in this case, specifically on the oncological patient. We've been following processes in various countries, and I would like to register that Brazil is far ahead when we compare the social participation on the assessment of health technology, and this shall be recognized. This is a process that we've been working on throughout the last decades, but we have something to improve. But our biggest gain is not only the right to social participation, but also an effective participation. We have to understand this value and how it's understood at the tip, at the patient's life. And then regarding the view of the cancer patient, no matter what therapy, innovative or not, and what we've seen today is a bigger focus on the follow-up of the advancement of biotechnologies and genetic therapies. But the focus of the patient is on hope, a new possibility, remembering that the oncological patient is a patient that doesn't use only one therapy. They face relapses, they are tired, exhausted, and they see in any possibility of therapy a new chance for survival and cure. The cure is the outcome that is the most desired. There is no way of escaping this expectation from the individual point of view for those who have the disease, and also from the collective side, with widening the information and having information available of these therapies in everything that happens in the community, the scientific community. And it's so great that we have this possibility of communicate the therapies. The patients that have some questions, they know the scenarios and they are inserted in this scenario. And there is, yes, great expectations. I've brought a quote here. I'm not going to read through it, but we've been following the CAR-T expectations. Dr. Vanderson yesterday has explained everything that is going on, and we keep up very closely with the researchers in this area. And with national and international medical community. And I myself dedicate to this theme to bring more information and adjust it when I'm going to communicate with our community of patients in Brazil. And communities of patients are very powerful and they are transformative. This is one of the first patients who had, he was the first patient to have CAR-T access. But we have testimonials of other patients. But they go all in the same sense, a new opportunity of living. Why are technologies, if not for transforming people's lives? This is a patient I've had the opportunity to listen to in the international scenario, and it grabs my attention. We said that therapeutic innovation brings back the possibility of dreaming, and this is what they want. There are many questions related to this therapy in particular, but with others, but the patient never asks how the health system is going to make this available to them. This is not a preoccupation of the society, not not of the patient. This is a preoccupation for all these other stakeholders. What the patient wants is, how can I access? Do I have access to it? Is this an indication for my case? And how long does it take for me to be cured or to prolong my life? So this is a scheme, because we sometimes forget we are inserted in this theme and we are deep in this subject. Sometimes we get lost and we think the patient will have the same perception. But when we talk about innovative therapy, sustainability, HTA, cover, access, the patient hears what is in the second column. When it's going to arrive, what's the treatment, is this my chance? What can I do to get this? They are not wrong, but we are committed to involving the society in this debate and explain to the patient mostly what role they have in this scenario and how they can contribute with the process of discussion and evaluation, assessment of the technologies. And above all, how they can improve the process so that their perspective is inserted, and when there's a formal possibility, they can participate. Our challenge is huge, but it's not different from any other country. We've been working collaboratively with other entities, with various specialists, contributing with our movement, everybody together against the cancer, todos juntos contra o câncer, and we deepen the themes and we build some propositions, some alternatives, pathways to propose some solutions.
These are some of the opportunities that we can build together a model that can meet this challenge. As Patricia told before, this is a challenging scenario, challenging for the whole chain, for all the stakeholders, and also for the patient associations, and obviously for the patient themselves. And if we do not leave this comfortable spot that we have been using the current methodology, that we are more We rely more because we can control the process phases and the outcomes. If we do not leave this place, we won't be able to have this new building, this new building blocks, this new proposal in order to meet the goals of precision oncology. And this will demand huge efforts and also agility. If we are not agile, we won't be able to follow up the technical, scientific technology. There is a detachment of timeline. We cannot track the investments in developing new therapies and technologies, in approving them and making them available. If we do not align on these matters, we will be ineffective. We will not be able to meet the HTA demands. We want to be able to deliver value for the ones in need of it. Without a doubt, we need to enhance transparency. And it's not only the information rights transparency. Without a doubt, transparency brings social engagement. Transparency also helps us building political commitment, having political agenda that is positive. And transparency makes the patient more protagonist, a more participative person. And the patient with transparency will be able to engage more effectively. There are many challenges with HTA. And we have Brazil scenery that was mentioned yesterday. We are delayed. There are many barriers to make medicine and technologies available. We need to face such a challenge as well. And we need also to provide more transparency in a public panel. We need to show the status of availability of such technologies, so that this new technology gets to the patient. Only to talk about the community point of view, I state. If we can understand how this group of more than 100 kinds of cancer, and they affect the patients in a multi-dimension way. If we understand these potential problems of the diseases, we can see how challenging this is to society. And we need to continue enhancing our health system. People talk about the advanced therapeutics and immunotherapy, CAR T cells, and all treatments. They ask if the patients are ready to receive these advanced therapies. And I say, patients need to be ready to understand how we are going to incorporate and make them available. And we need to see the conditions for this access. We are completely aware, and we are responsible when we say the technologies need to be made available for the right patient in the right time with the right criteria. So clinical trials results, eligibility criteria, all these metrics and technical requisites, they are not at play. We need to develop together a way of absorbing these new technologies in the right time for the ones in need. This way we will strengthen the public health system and will find a sustainable way of doing so. We strongly believe we need to intensify the competencies of the stakeholders, and we need to strengthen the public bodies. Second, centered, an approach centered to the patient needs to find a balanced way to discuss the cost benefit, cost effectiveness, delivery of value. And we need to center the HTA approach on the patient. And this is an effort that needs to be done in Brazil more and more. If we don't do so, we are going to risk having an excellent network of HTA that will never be made available actually to make an impact in the patient's life. We need to commit together in a collective effort and make everyone to bring their contribution for the process. It's possible to make it different, but we need engagement of everyone. Social participation is not only to complain on things are not working. Social participation is to add value on the effects in the real world. And we need to speak up and help the decision makers. Here in Brazil, there's a gap because processes are not transparent and there's a low engagement overall in the society. And this is still dark for us. We can't understand how the contributions of patients will impact or not. And how strong that is in the decision-making process of HTA. This is extremely important. We need higher transparency. We need to qualify participation. And we need to clearly show that we are doing so to incorporate or not the technologies. This is important for the outcomes in the HTA process. If we can advance on this transparency, we will achieve a lot. And we will be able to say that social participation may have a practical effect in HTA processes. Otherwise, we will only listen to many patients with hope or frustration, and we want to have an effective contribution from society. Thank you so much for having me, and I'm at your disposal for collaboration. These are my details, my personal details to get in touch with. Thank you.
Dando sequência à nossa programação.
So let's continue our schedule. Now we have Dr. Joyce. Dr. Joyce is with you. Dr. Joyce Valentin. Good morning. Thank you so much for having me, Maria and Patricia. It's such an important event. I'm honored to be able to come back to the university I studied at. I'm going to talk about HTA, models of financing, thinking on innovation, access, and sustainability. I will focus on economic sustainability that was already mentioned. And I'm also going to talk about the value for the society and health system. I'm leader of global HTA strategy at Roche in the pharma division. I work at Roche. I have been working at Roche for 10 years, and I have worked for Latin America before, since 2017 in the Access Global team. I'm a representative of the industry and scientific societies and pharmaceutical chambers. Before working for the industry, I have worked in academia and the government. I worked economy at FAIR, at USP, and preventive medicine. And Maria was my coordinator. And this doctorate degree was so valuable for my work. Today's agenda is the following. I will talk about some of HTA aspects, We had great experts presenting lectures in these 2 days, but I'm going to talk about a more proactive role of AGTA. We have been working the system shaper topic a lot. I will talk about the stakeholders and evidence. I will talk about the facilitators to have an AGTA process flexible, bringing the industry point of view. I'm going to present financing models, and I need to provide credits for my fellow partners. I'm a GTA specialist, and I have friends who helped me. I will conclude with public-private partnerships, and I see the link with Abrali's presentation about UICC, and I will talk more about this. It's important to remember the denominator, the common denominator for these 3 topics, which is universal health coverage, and the Millennium Objectives to be achieved by 2030 as a commitment of many countries. And this is also Roche's commitment. Now talking about AGTA as a system shaper, a more proactive role. Now we need to rethink healthcare investments. Not expenditures, but investments, and also maximizing patient outcomes. Many of you must know AGTAI. AGTAI is the International Association of AGTA, Health Technology Assessment International. In this year's annual meeting, the keynote speaker was Professor Rifat Eitan. He was my professor in 2004 when I received a fellowship to study in the United Kingdom. He has been working with many countries, and he has worked with Brazil, Chile, and many others. He was very eloquent when he talked about the AGTA importance as a model shaper. A system shaper, I mean. He worked to improve the health systems as a whole, not only the AGTA part. When he brings the data, there's some disconnection between the goals, what the people have been doing, and the future planning. There is the AGTAI channel on YouTube, and you can see this presentation. For me, this is one of the best presentations I have ever seen. I have always believed in AGTA's role as being more proactive. And in his presentation, he talks about many examples. Now, talking about value and AGTA normative, the Varja talked about yesterday. Catherine talked about it very thoroughly in other presentations. Value is not only prices and immediate impact in the patient's life. There are many other dimensions. People talked about the different perspectives, pre-can value, and also the value dimensions. And in the industry point of view, and contributing for society health as a whole, when we have innovative treatment, we increase quality of life, we increase the ability to contribute to socially and economically. Also, relief for carers, reduced burden on healthcare systems, and also reduction in treatment delays through improved adherence. As time is at the essence, and you will receive this slide, there are links for many studies and reports. They confirm what I'm saying. There's a German institute called VIFOR. They have been working with many different governments. In Latin America, they are on Peru. They have a report as health as investment. And I would like to talk about horizon scanning. This study is in Brazil for Latin America. Among horizon scanning goals, you can also find it transparent on Google. There's an example for Scotland. It's about future planning of HTA and treatments that may be used. Of course, we must have consonance with health public policies. And the public health system can get prepared for the innovation and talk to many different stakeholders, including industry and innovation developers. Talking about HTA as system shaper, I talk about the industry role. And I talk about HTA. This was published in 2020-2021. You can find it on our webpage. And we also have been considering the way we work globally. And I talk about the update of HTA definition that Varja presented yesterday, life cycle, value dimension on every stakeholders, not only on efficiency, but also on quality. As I work with different regions, and I could visit Taiwan in an HTA-I visit in Thailand. Then we saw equity and efficiency for the population, and this is a value for the society. And I'm very proud to say they work this way. And for our HTA position, we consider definition that Varja presented, and there are three pillars that we thought they are commitment from the industry and a conjoint work with the different stakeholders. HTA comes from the country and for health system. But we understand every stakeholders can contribute. So we would like to talk about our view and how the industry can collaborate. We need to think in optimize and make the adoption of technologies easy. So these pillars are fit for purpose, the sooner the better, in a consistent way in the HTA process as Maria presented. And along this process, there are different points. So this, for inclusion, we can have different points of inclusion and dialogue. There is the monitoring, horizon scanning needs to happen in the beginning. And also for the different points of HTA or assessment, as Patricia highlighted yesterday. These reassessments could also consider a broad dialogue and also needs to be transparent, as Catherine has just said. Adopting a scientific, rational, and adaptable approach. They need to capture different dimensions of value and criteria. Carolina presented in a very complete way how Conitech has been considered multi-criteria analysis, not only focusing on clinical and economic dimension.
So the importance of considering these different criteria from the perspective even for the caregiver. We have other dimensions such as equity and environment or sustainability. These two themes are being worked on globally. Thinking of society, I'm going to recall these over the next slides. The health systems have to consider the perspective of the society. So the cost estimation in a wider way, not only the costs that are on the health system. And then thinking of innovation, adaptable approaches. something like precision oncology. How does HTA can elaborate evidence? Another important point is the evidence itself. Since Maria mentioned, the information is going to become evidence. And the science objective is to use this evidence to inform this decision. We have to remember that this evidence, that it is different depending on the actor. Just like the generation of this evidence by distinct actors and their respective acceptance is different. It's important that the evidence generation is wide and the top quality, having respect for the various actors to be accepted. Because today we have a lack of dialogue, of conversation to find this solution. And I would like to reinforce that this evidence shall be wide, real life data, and also the perspective of the society, considering costs on avoidable costs and the impact on the society. I was not able to have all this information clearly, so our next slides are taking the main messages. But we had an internal exercise for 5 groups of health technologies. And we asked what challenges are regarding HTA and what can bear HTA with the focus on innovation. These groups are genic therapies, including cellular therapies, rare diseases, specific mutations, rare cancers, and agnostic cancer, precision oncology. These are related to the design of clinical studies, the kind of evidence and certainty related to the payment form or the performance of the result. I would like to highlight that out of these 5 groups, the precision oncology is the group that the most benefits from these facilitators. This has been an internal exercise. It hasn't been published. And the findings were that we have 9 facilitators to flexibilize or improve HTA for innovation. We could group them in 3 related to the design of the clinical trial, such as basket trials and innovative designs, and the acceptance of these new models or designs of clinical trials, and the sources of innovation, such as real-life data, and the recognition of wider results for the patient. We talked about hope, about getting to know about the therapy for the health program by improving diagnosis and the innovative diagnosis. And also the agreements, the risk-sharing agreements and innovative payment models. There's a publication from the Economist Intelligence Unit that is specific for Latin America. You can find it in English, Portuguese, and Spanish. That reinforces these exercises that we've done. This study is called Personalized Medicine and the Potential to Improve the Sustainability in Health Patents and the Result in Health Services and the Results for the Patients, analyzing the health system from the diagnosis from the individual service and the need for payment systems. In this exercise, we've called the risk-sharing agreement and the monitoring of specific data, as Patricia recalled this morning, to find the right patients on the right moment for personalized treatment. I've included all the links. You can see the references after. Going to the next model is the funding models. The source of finance, its nature, dividing them into government and compulsory insurance, as well as private schemes. And what are their respective models? In Brazil, we have public funding through taxes. Before SUS, it was a salary payroll. We had a model related to employees and employer. There are blended finance models as a double source of fund with two natures, and the private schemes that come from volunteer contributions, such as the private health systems, donations, support to patients, and the last one with more impact on families negatively, that is the direct disbursement. In our view, with the collaboration of various actors, the best solutions or the best solution for the country would be the blending of various models. It's not just one model that is going to solve this. Thank you. These distinct solutions can complement one another. We don't rely only on the finance. We have to have education and training on the service and product, and a dialogue to understand which solutions are best and how to monitor them, and if some models can or shall be changed. Here you can have more reference. This has more details, and it's opening the financing source among subgroups, public and private, their functionalities, and how they can connect. This is the oncology area, together with Hoshi and other collaborators with non-transmittable diseases. We have examples from the whole world here. Regarding conceptualization, we've brought that innovative concepts. We are talking about all kinds of innovative models. They are a compound. They have various models together. They are considered innovative in this way too, because when they happen, they can be defined as public-private partnerships regarding their nature of funding. This other work is an exercise to step ahead, to advance solutions for to the G20, thinking of the Health Commission and direct disbursement. In the report, you can see all the steps. I highlight steps 5 and 8. My yellow arrow has vanished when I converted the document to send. So 5 is the construction of the dialogue and understanding as early as possible, and the consensus on metrics and the return on investment. And of course, the step 10, that is incentive and implementation. By emphasizing the role of health as investment, the V4 Institute has developed a technology to demonstrate economic impact, and this is specifically for Latin America. We have 6 countries, including Brazil, and the added value. At the coffee break, I can talk a little more about the methodology. In the link, you have taxes, salaries, economic multipliers, and company multipliers, and that's the contribution at a macroeconomic level. The public-private partnerships is very important for the collaboration, for diagnosis, for the implementation, and for the balance of inequity. We have 2 collaborations. I brought 2 because of the time. Catherine has mentioned already or listed, and it's very good to have her contribution from ICC, the Association for the Fighting Against Cancer of Central Brazil, ACCBC. This is the oldest and the bigger association, 1,100 members. in 170 countries to improve the cancer treatment with distinct actors. And the other one is the City Cancer Challenge. In Latin America, there is in Paraguay and Colombia, with initiatives for the improvement of qualities and projects on the treatment. We have other initiatives in various countries. I can talk a little more throughout the coffee. I won't cover here. So I would like to summarize my presentation by recalling the idea of the objective of the health service, the challenge of the partnerships to improve the control of all diseases, because we are going to be somehow patients someday. So by thinking of the service and the care, we have to think of quality, because we can and we are committed to it. And we have to think of the financial reality of the population. Thank you very much, and congratulations on this event. First of all, I would like to thank Catherine and Joyce for their contributions. I'm going to introduce myself rapidly. I'm Alessandro. I'm part of ICESP and connected to the Oncology Center in the area of HTA, and part of the EETOP, this research initiative together with IA. We've predicted our coffee break. We've planned our coffee break at 10:10. So we have 10 minutes. Is this 15 to 20 minutes? Okay, great. I'm trying to facilitate to mediate the debate of these participants. I'm going to have some considerations, and after I'm going to open for you. We've been undergoing this health based on evidence, which is best for everybody, but we are expressing a point on where the expertise-based health is. I'm calling expertise not only the formal education learnings or literature learning, but the expertise that is more empirical learning of the actors or the agents, so that they can have diagnosis and prognostics and communicate in a good way with patients. And also the expertise of the patient that can understand and live in a context that is influenced by the experience of the disease. So we can think, and some authors think that the expertise is internal to the evidence, and there are some authors that, on the other hand, think of something external as expertise that would be complementing the evidence. And there are the ones that think that it's a hybrid thing, both one of them or at one point and another one from another point. So I would like to invite you to reflect on that, because the participation of the patient can be used as inputs, as testimonials, but can be thought as a system of evidence that can have contribution. And I would like to highlight the system of evidence based on the knowledge that comes from their expertise. They can help out in the mitigation of the uncertainties of the other evidences that come from the scientific literature. To do so, however, they have to deal with their own uncertainties. So I would like to invite my colleagues to think a little bit about that and how this has been influencing the finance or funding issue. Because Joyce mentioned that services that use a given technology can be able to implement such technology in a different way. They can have clinical governance that is different, or the management of cases and diseases that can be thought as technology, but can bring different results. So this somehow shall be visible for the finance system because we need funds. So I invite you to think this way. And the Joyce brought something that has caused me an impression when he think of this as a modeler of the system. I was wondering if this is actually true or not. What proposals of value we've been doing to this system? What would be the ideal care once most of the technologies are drugs? Are we giving this information to the community? There are things called opportunity costs. So how are the other items based on prevention and all this in the system as a whole? So this is an invitation. I think it was really rich. We have to express all the perspective to reach a critical understanding that is wider. Those who would like to have considerations, we have a microphone available. Muito
Muy rico in Spanish. I'm also struggling a bit with, indeed, health systems perspective, which I adore, but because I believe in this, and for me, HTA is about health system strengthening. So I'm in your presentation, Joyce. But to say that we would like to have social return on investment or economic return on investment, for me it's also maybe a bit too mechanistic in a sense that you try to put it down to a number again, because this is all about, you know, the social return on investment, and the economic return on investment is leaving out, I would say, also the story, the more the qualitative aspect, because we are trying to measure something in a quantitative way. Fair enough, but you know, it's the same with quantitative MCDA. I don't believe in this, because you miss out indeed the deliberative component, what you were talking about. What is the qualitative? So the qualitative notion here, or what is the meaning of this information? So I'm struggling a bit with this concept of reform, because I've done studies myself in this area, and I think we need both. But that's my I would say epistemological commitment to how we do research, and that I think also then the story of the patient comes in, and what you're referring to is indeed there is patient-based evidence. And the collecting of patient-based views need to be collected in a scientifically, robust way. We call it patient-based evidence. And then you have the experimental knowledge. And so what is it that a patient can bring to the table that really shows what it is to live with a disease in a more qualitative way? And I think we also need both, because one is indeed to say what is the evidence, underlying, the experience from patients, either in PROMs or in PREMs or in other qualitative measures, quality of life measures, as well as the patient story here, which can really, I think can bring across what it is to live with a disease that, for example, appraisal committee members do not know. And I think for me, as a chair of the appraisal committee, or a member of the committee, this is very valuable. So you also have the story behind the numbers, and that's maybe my point. The story behind the numbers is very important here. So just a reflection from my side. Thank you. Not really a question, but yeah, go ahead.
Thank you so much for your comment. Maybe it is important to clarify that. I agree with you. As I had to cover 3 bullet points in the context of universal health coverage, the metrics are specific for financial models. and to aid a dialogue, to understand health as investment and not expenditure. These metrics are not definers, but only to transform it, to make it more concrete, to make the dialogue easier. So clarifying this suggestion is not for AGTA, is to have an AGTA view as a modular, a system modular. Of course, the qualitative evidence can complement also. Good morning. Congratulations for the excellent presentation. I would like to ask you something regarding a topic that both of you talked about, which is value for hope. We could be in the great summits of AGTA, in the international congresses, AGTA-I that you mentioned was one of them. You talked about value for hope. Some European countries mentioned this as being important. AGTA-I, I was not there this year, but how do you work with value for hope? Do you have any proposals for that? What is the dimension of value for hope? This is important. Have you been thinking of it? How would you approach this dimension in the AGTA? I'm not sure if I can answer your question fully, but I'm going to share my views and what I have been listening when I talk to friends and people from other countries as well. Regarding value for hope or any other data that is qualitative in the AGTA process, we have some barriers, and some of them are internal for the methodologies used. And in this case, we need to revisit these methodologies to know how we can add some criteria of value for hope. And this is very important, and when we could do so, and how we would do it. I'm pragmatic. Add this value only for doing so, this doesn't make a difference. It's more social awareness than an application to promote impact. If we are doing it to add this value fully and develop potentially some impacts in the decision-making process, in this case, we need to study to understand when to do it. And there's another barrier, which is the challenges in collecting this data of this value and considering it for the patient's perspective. As any other qualitative data, this is a challenge. How can we do it? How can we collect this data, analyze and present it in a structured way? How can we make it objectively? We need to consider objective criteria. There are efforts being done, but in some European countries this is done. But as I see, it's still incipient. And this is, for now, is only to promote hearing people. We are only adding this patient's perspective, and we are not doing so to transform it into AGTA practice or outcomes. So these are the barriers we face. But without a doubt, we need to find a path to do so. If we see how we can translate value for help, there are many ways to do so. Individually, there's a more emotional impact to transmit the effect of value for hope in the individual patient's journey. But when we systematize it, there are many criteria. Many of them Joyce has mentioned, and they are closer to the sense of analyzing a more encompassing life cycle and a journey not only as a patient, as a citizen, as a producer in a social context. So there are many elements to be considered if you add the value for hope for a positive clinical outcome as being incurred. But I'm hopeful. I'm hopeful that we will progress. Study groups have been studying this matter, these potential improvements in the methodology. These studies are so essential. We want to be able to promote change if we do not do things. We need to think in a more disruptive way, and we need to have actions in order to achieve it. Thank you for the question. Catherine has answered very well. I couldn't do better. But this is a proposal, and we need to advance a bit. We haven't been advancing as we imagined. During coffee break, I can show you a Lou Garrison paper. He proposed the value for hope that we mentioned, and he analyzes a potential to use these other two dimensions of value more, including value for hope. Still on what Varja talked about, and as Catherine mentioned, there is the matter of accepting the qualitative evidence or considerations, patient reports that could be considered in order to effectively inform the decision. Depending on the nature of HTA and its promise, what we call transforming benefits, thinking on potential cure, remission. Maybe value for hope would be higher depending on the patient's age. There are many considerations to be done regarding patient pathology, progression, how much therapies could contribute, but we still need to advance methodologically, and also the interaction between the stakeholders. Good morning. I'm Ana Carolina. I'm the coordinator of monitoring Technologies of Health in Executive Secretariat of CONITEC. It's good to be part of this debate. There are many things I could help. Professor Patricia and Maria, I hope we continue with this debate. It's such a productive one. I have just defended my doctorate degree with Professor Patricia, and I'm restless about the impact of the contribution in the public consultations regarding CONITEC's recommendations. I have analyzed the first 10 years of CONITEC's work. I'm not sure if it is already available, but I can share the publication. It's my own. Despite the available spaces, the great volume of participation, this is still a barrier of having an effective inclusion of this contribution in decision-making processes. Trying to contribute on this discussion proposed by Joyce, I agree Professor Ripat's presentation was the higher point in this summit. There are many uncertainties when we signed the agreements of risk, and we are unsure because we do not know the effect of technology in Brazil. We need to think how we could make this inclusion happen in developing the technology. So when it comes here, we are less unsure. In these agreements, I personally feel as if the burden of proof would be inverted. the producer is not going to prove the value of technology to be good enough to join the system. First of all, the technology enters the system, and then the system needs to prove technology is not good enough. And then I would like to share this restlessness so that we can discuss it further.
Com a pergunta da Carol, e aí eu
Let me ask my question. It's very well aligned with Carol's question. When we have mechanisms of payment, sharing risk that happened in the incorporation of Josema in Brazil, we had the beginning of this process of design of this risk-sharing agreement contract. Catherine has worked in this a lot. Beyond the literature of LCHTA, they talk about changing this model based on value and being risk-based. As we're going to have precocious assessment that is closer to the development, when we have more uncertainty regarding risk on this medicine, especially the fast-track access. Sometimes in phase 2, it's already incorporated. Many times they have promising medicine. When they go to phase 2, phase 3, they do not work. So these mechanisms are agreements, risk-based agreement. The higher the risk, less we should pay, because we are providing access so that the technology gets to the market earlier. So this payment should be crescent as the risk diminishes. And then they could show the promise will be accomplished. So I would like to hear from you about these new risk-based models, performance-based models, because the dimensions of value, it is very difficult to collect data and transform them into evidence in a standardized way. It's a methodological path that is still distant from operationalization. There's the value flower concept. From the concept to its operationalization, to make it an evidence to be used in decision-making process, I think it is still a long way work ahead of us. Could you talk about this performance and risk-based methods? So let me see the questions. Carol, the first question is about uncertainties, and afterward about the models. Uncertainty again, talking about the models now. About uncertainty, the world is more and more uncertain in many aspects. There's a whole context that go beyond health. This is my personal perspective. There's a very important study from AGTAI with another institution. Vaja leads this study. It's how to approach uncertainties for the regulatory objectives, considering different perspectives. They may be uncertainty things on outpatient and for other different actors. We need to accept risk and deal with uncertainty. And this changes from patient to patient. If it's a higher mortality, people want to treat with these uncertain treatments more. So these are conceptual things about uncertainty. On the industry perspective, as the uncertainty is higher, it's important to share the risk. There isn't an expectation if there is a shown outcome, if the risk is lower or uncertainty is lower, the sharing would happen. It's important to clarify that. So availability to share risk depends on how high is the risk and uncertainty? As for the payment models, there are many terms. Patricia mentioned phase 2 studies and other things. In oncology, it's more difficult to have this from phase 2, from phase 3. In rare diseases, depending on the size of the sampling, I have worked with other uses where we have regulatory approval for 28 patients with a spectacular results. So it depends on the case, on the phase, the clinical studies. We cannot generalize. It changes case over case. As for Carol's question about effectiveness, there's the ideal world in clinical studies, clinical practice changes, and this effectiveness monitoring is important. And there is also the role of real world data. In AGTA-I, they have already presented this topic, which is transportability. They do not talk about generation, they talk about transportability. And country as Canada, they already present RWD from the same groups of populations. There are many techniques. If you are interested, I can connect you with these experts of our team. And then you can use data of other countries as a proxy for this inclusion. And it depends on the outcome used, how you are going to monitor it. The first time I've worked with that was before 2010. It was very important for the private sector. It was an agreement on how we would monitor. And in a legal point of view, it was so difficult, and everyone was well-intended. I'm not going to talk further. I will, on that note, Ana Carolina, you are already famous. I knew about you before getting here. I would like to read your entire thesis. I would like to work with you in order to learn from your perspective. What you talked about was super important, burden of proof. And so, in a so uncertain scenario, the only certainty I have, and I'm not an expert, any effective solution will go through collaboration, and it will demand complex arrangements. And for me, the most important thing, and for other scholars also, our internal capacity of operationalize and training needed. This is something that is more important. We need to regulate, assess, measure, monitor, all these arrangements that are so complex. I worked 10 years with PPP in health and other innovative models of management in different countries, Europe, Central America, and in Brazil. And I can tell you, information is not lacking, creativity is not lacking, and goodwill is not lacking. But we still have a systemic deficiency and a myriad of capacities we do not have. We are able to do it, but we can't do it in proper time. We cannot implement coherently, consistently, in a legal and political stable environment.
Not about management capacity, but on these two pillars that are key for any commercial arrangement. I've participated in June. We had two round tables with manufacturers. We had representatives of the main laboratories that are advanced in therapeutic products delivery, CAR T therapies. I was at EHA in the European Congress of Hematology, and the CAR T was the focus, but it's okay for all the others. And there were representatives of government from European countries, and there was a person from the European community, the European Union. And what they were presenting were their struggle to make effective some agreements in this sense. So we also have to think that these are difficult conversations because on one hand, you have the businesses to mitigate their risks of these arrangements, and they bring some propositions that are not always fulfilled as counterparties from the governments to have a favorable scenario, being to refuse or to welcome demand to make it sustainable. Because worse than a scenario of non-collaboration is to have a commitment of both stakeholders and not being able to make this service available. The level of commitment make it serious in the sense of all the time of sustainability, of maturity that these agreements will have to be needed. This is what is a big challenge in our scenario. These are my considerations. I'm pretty sure that we are going to reach agreements that are going to be risky, of course, but we need a pilot. We have to start and to pay for this. We are not going to have any other alternatives. We have to commit and have a social responsibility to make it happen and to follow what's going on in other countries, having our feet on the ground, that our scenario is very particular because of our instability elements and inefficiencies of management. We have our last three questions, Carlos, and after Maria and the other professor. Carlos Rezende, I'm coordinator of the technology management coordination of ANS. When I talk about technology management, by the infrastructure, we can't cover the whole life cycle of the technology and the follow-up after its incorporation. The same way, we can't keep the monitoring, the technological monitoring that is fitted and suited to it. But we have evolved in transparency. But the transparency needs to evolve so that we can communicate with patients. This is a very important point of this discussion today. The challenges are huge and the process is becoming more and more complex. So how can we join this all and transform this process in something more understandable for those who are participating in it as patients and family members? Whereas in our experience is that the businesses are participating in this process, they are incentivizing the social participation, but it's from the point of view of incorporation without the analysis of the whole process, advantages and disadvantages of the technology. So what I see and we can bring in the group is that the more complex, the more difficult is to incorporate, mainly because of the industrial aspect. Evidence of the real world, basket clinical trials, target therapies, these all bring costs and reduces the niche of introduction of such technology. So we see the widening of the industry regarding other aspects, for example, diagnosis. So here's my question to businesses. and now I'm directing it to Joyce. To what extent the widening of diagnosis and sharing risks don't bring to us, for us as students, does not bring a mechanism of cost sharing of assessment, clinical trial, to bring this to certain health systems? This is the question I would like to ask, because we talk too much about sustainability, but this is going to impact on our sustainability when we start to transfer resources that were supposed to go to the treatment within these mechanisms of sharing diagnosis, more and more specific and expensive, because they go as they go to the genomic aspect. I'm going to try to answer quickly. You mentioned clinical trials, but I have a question about your question. This is a question from those who invest in the clinical area. We have to recall the matter of all the investment for the development of therapies and innovative diagnosis. The idea is that as you find the right patient, you avoid spending with other patients that wouldn't respond to it. So you have a saving on this hand when you find the right patient. But there is a cost for this diagnose, this innovative diagnose. This component is important for the whole approach. We are not going to solve the risk, so we have to simplify. We only go to complex agreements to demand more investment when the risk is high regarding the outcome. There are various models and are simpler ways to do so. And there is also the funding of the trials. In some countries there are agreements. We need dialogue. We need agreement. You are using medications that are not going to respond. As a whole, we have an inefficiency in the health system. So if we save this money and we can reuse it better, we can channelize it for other diagnoses. Considering what is going to be said after, I would like to add, I've talked yesterday, I have a general view from the macro to the micro. It took us long as health PA to consolidate as a method. I'm based on my scientific methodology. By the use of science in a world that doesn't use science. So we are going to use science so that everything is better. It took us long. I remember when I put this in a congress a short time ago. I said, it's a policy. What we're seeking to do is an HTA policy. And we face some difficulties to get this because we don't know, we can't identify our allies because we have only convenience allies. The doctor hates HTA because it bothers their work. Only at some moments they think it's good when it goes on the direction they like. Businesses think HTA is good, but it bothers. In my area of collective health, we don't like it. We have difficulties. How about the other themes general health, society, SUS as a whole, we have difficulty to put ourselves as participants of the health policies in a more comprehensive way and more expanding way and more and truer. Even at the Ministry of Health, I have nothing to lose, so I'm gonna say it. Even in the Ministry of Health, the huge difficulties is that we have disconnection. There is no coherence in the ministry. Also with the society. We have to seek to do better this discussion of these particular questions by recognizing where we are, who we are talking to, transparency, and who we are and what we really think, to be able to be more efficient. I would like to comment. I need to comment because I'm a sanitary doctor. I would like to bring a practical example. We are thinking oncology in a special moment. Through the Todos Juntos contra o Câncer, which is a task force of many stakeholders, we have a point in common. Is the agenda of the improvement of oncological attention. We are at the moment of regulation and implementation of the new policy of prevention and fight against cancer. So there's no way of building consensus in a scenario with many interests on the table, in which we don't understand who are the supporters. There's no way other than finding a common agenda and deep dive in it as a transformative agenda. We've been promoting at TJCC, but getting the policy as an integralizing element, of course, with distinct vision. But this recognition is important, and I'm convinced that there is a common outcome that we want to reach. And in the middle of this chain, we have so many components. So how can we get there? I see no other way other than involving the whole society and having difficult conversations that have to be thorough and public. Everything that is going to cause effect on common well-being needs to be transparent and wide. And we have to bring the accountability of communication medium. They have to open space for dialogue and debates for this positive policy in Brazilian society in collective health. So let's go ahead.
Agreements, and I fully agree with what has been said, that this is very difficult to organize, specifically the performance-based one, and there's a clear preferences from ministries of health for the financial agreements, so the negotiations. And we do know that in order to have the performance-based agreements, we have to have indeed an infrastructure to collect the data. There need to be patient registries, for example. You need to work with the clinicians on appropriate use protocol. And of course, sometimes this is feasible when the medical societies do have already an appropriate use protocol in place. And this is something that we, for example, always ask when we do the deliberation about the appraisal about a certain drug. But I would like to remind ourselves that why do we need financial negotiations? So because we are talking about, okay, I mean, it's in line with what Carol said, is if the business model would be different, then we would not necessarily need to have financial arrangements or performance-based agreements. So we are talking about indeed a private, fair enough, a private price for a drug because, you know, industry is a private company, but in a public market. So in order to, you know, this discussion that you had, okay, you know, we have to deliver the proof once it is in the system. I think the proof should be earlier, right? So it should not be on the public system. It should be indeed, the burden should be on those that have the risk and not those that, you know, would like to use the product. But this is a bigger discussion that we will not solve. But I think we, I mean, as a society, need to think about the biomedical model that is underlying the product development and the commercialization of the products. But that's maybe for another conference. But I just want to remind ourselves, performance-based agreements, it's nice. There are some templates, models that you can use. For example, in the orphan disease area, for example, in Europe there have been performance-based model agreements been developed that potentially maybe Brazil might want to look at if they want to use it specifically for orphan diseases. So you can learn from others. But what we perceive in the Netherlands is that there is a clear preference, there's also been research on this, a clear preferences for the financial negotiations, because you can have, of course, 1 year negotiation, negotiation for 1 year or for 2 years, 3 years, and then alongside do the collecting of the data at the burden of the pharmaceutical industry, instead of having all these registries in place and trying to come up. Because we do know, I mean, and I don't know, I think Carol referred to that study. We already know that potentially for a lot of cases, this is not delivering what they're supposed to deliver. So why are we doing this? Why are we doing this? So, fundamental question, sorry. Yeah.
Excelente discussão, a gente fica sem querer parar, né? Mas vamos dar uma...
Excellent discussions. Let's pause and go to the coffee break. 15 minutes and go back.
Parabéns pelo trabalho. Ai, parabéns para você. Sua fã. Eu também leio tudo que você publica. Muito obrigada. Você lerou muito bem. É um prazer te conhecer. Então, obrigada. A gente avança agora nos estudos. Isso é só pessoal, né?
vamos retomar.
Let's resume our work. I would like to invite Professor Widja for the last presentation, integrando a participação dos stakeholders e integrando uma análise normativa em ATS.
Thank you so much. So I am very happy to be here again. I was here yesterday, sorry. For those who don't know me, my name is Weijo Oudwijn. I'm professor at the Radboud University Medical Center. I'm also the chair of the appraisal committee in the Netherlands. And I think Patricia gave an excellent summary of my presentation yesterday. I really enjoyed seeing that in Portuguese. I made a picture of it so I can show it back home. So it's really, really nice. And I think we heard also great contributions already before the coffee break. And my presentation is very much in line and potentially also overlaps with what you have heard this morning. So I would like to speak a bit about stakeholder participation and indeed how to integrate normative analysis in HTA. That was actually already alluded to yesterday, and I spoke a bit more about that yesterday than today. So I would like to give you a feel for how important stakeholder participation is, but also how you potentially can organize this in your own settings. I would like to remind ourselves about why we are here in terms of what we try to achieve with, with the Sustainable Development Goals. And one of these goals is, of course, obtaining universal healthcare coverage. And I think it's a commitment, and that's also a normative commitment of member states around the globe to indeed try to achieve universal healthcare coverage. Joyce already mentioned, in order to achieve universal healthcare coverage, we need to try to achieve not only financial sustainability in terms of the financial protection, what you were talking about, but also to have equal access to care that is necessary. And so the essential healthcare is here very important. And we also, I think all of us know that indeed health technology assessment can be used to inform decisions that try to enable universal healthcare coverage. Why I like to show the Sustainability Development Goals is also that very recently social participation has been named as a very important commitment, again, from member states to have participation in the achievement of universal healthcare coverage. And recently there has been a WHO resolution in Europe that was taken on board in April during the WHO assembly, that member states will use social participation in the achievement of universal healthcare coverage and in well-being. So this is very fundamental, I would say, and it's an achievement. It's for the first time ever that this WHO resolution has been agreed upon. So I personally will think that there will be more emphasis on social participation in the years to come. So that's I think a very good sign, and I also do know that WHO, but also PAHO, of course, in the Americas, will align and will have to support member states in organizing social participation. Why this is important is, and I mentioned that yesterday as well, is in order to have legitimate decision making, it is not only about the evidence as such, but it's also about the process and the stakeholder involvement in that, in order to have what we say legitimate decisions. So because a decision is only seen as fair as people that were involved in this process have the feeling or the, the feeling or the commitment that they think this process was fair, and therefore this decision that was taken is acceptable to me. And I think that we all agree, once a process is transparent and the criteria that are used are explicit, and even though you might not necessarily agree with them, but if the process is done in a, I would say, a democratic way, you might want to accept it. That's how I think, for example, democratic governments work. Of course, we also know that this is aspirational, because we also have to deal with countries where there is less transparency, also in governmental decision making or the elections. But still, this is something that we want to strive for, and that's not always easy. And that's also why I think, indeed, and Joyce mentioned HTA as the shaper of healthcare systems, but I think HTA can also be used to have these more transparent processes in place if we show that this is important for robust decision making that also leads to more qualitative, better decision making for a country. And I think it's also our responsibility as a HTA community to show that this is important in order to make fair decisions. Not easy, but very important. So the principle and the criteria for fair processes are on this slide. I like this diagram because it's very comprehensive. This is based on an ethical framework that you might have heard about, the Daniels and Sabin accountability for reasonableness framework, and that talks about, indeed, that all stakeholders need to be involved and the relevant values need to be explicit. There need to be a process in place for appeal. The criteria need to be very explicit. The evidence that is used need to be very robust. And this needs to be publicly endorsed. So the public endorsement here is also fundamental in order to have a fair process. So here on the slide you can also see clearly two important components of a fair process, and those are inclusiveness and the term participation. And with regard to inclusiveness, that is also what many of us already spoke about, is indeed that we need to think about different stakeholders that might have a stake in a certain decision-making process. And it's not to say that you always need all of them in a certain decision-making, but at least you have to think about it, and also think about it whether or not you want them to be participating in this process, or if you want to consult them in this process. Also relates to the timelines that are available, also relates to the resources that you have available. Of course, ideally we would like them to have participation throughout the whole life cycle, that's very clear, but there are also trade-offs here that you need to take into account, because organizing meaningful participation is it's important, but it also might take some time, and I'm pretty sure Carol can also talk about, indeed, how you organize your social participation process in Brazil, the timelines for that, the resources that are needed for that, but also very important that we need to, for example, have to organize trainings, for example, for lay persons or for patients to have an equal footing at the table when you have participation. And when I talk about participation, that's the second component of having a voice in a certain process, is indeed very important to make a distinction between what we would call stakeholder involvement versus, for example, stakeholder participation. So when we talk about stakeholder involvement, people might mean different things. When, for example, I'm now speaking to you, so this is the one-way communication. So actually I communicate to you what my message is today. So this is what we say communication. And this is, for example, that you want to inform the public about a certain decision that was made by Conitec. So that's the communication. You put it on a website, the decision made by Conitec was this and this and this and this. So there is no two-way exchange. You just communicate. People might perceive this as stakeholder involvement because you communicated a message to the public. What we often see in most of countries throughout the globe is stakeholder consultation. So we ask indeed, for example, patients about their views or the public about their views, and it's the consultation. Clearly what Conitec does, they also call it public consultation. So they ask the public to elicit their views with regard to certain topics. Consultation also takes place in, for example, when you send out a survey to patients to elicit their quality of life preferences. That's also consultation because you just ask them to elicit. There is no way of exchanging the views of the stakeholders, and this should not be mixed with stakeholder participation, because participation actually means what we were doing this morning. You really have a discussion about your viewpoints, your arguments, and you react to each other in order to understand maybe each other, or maybe come to an agreement, or maybe come to a consensus, but that is not always necessary. It is about indeed exchanging your viewpoints, the underlying arguments, and so where do I come from? Why is this important for me? This is very important when we talk about participation, and we call this deliberation. So especially when we are organizing committee meetings, appraisal committee meetings, we ask every stakeholder that is a member of the appraisal committee to elicit their views on the evidence that is on the table. And we, for example, have also a patient representative in the committee. So also the patient view on that evidence, of course, in light of a social discussion that we need to have in order to make a decision on behalf of the society, is what we talk about. So people can express their views, we discuss this, and in our case we ideally come to a consensus, and if that's not feasible, we use majority of vote. But ideally that's what we try to do, and that has been happening for all decisions recommendations except for one. There we used majority of vote, because in that specific case, which was about reimbursement of vitamin D, the clinician perspective, the person who was one of the clinicians said, I really think this is not a good idea. So, and then that was noted. So it's very transparent why this committee member expressed her view of not agreeing with the majority of the committee. And this is actually very important, so you can understand where somebody comes from, and also how actually they weigh the evidence here. So if it's about marginalized, for example, disadvantaged groups, that also sometimes happens, but still then we might come to a consensus, because everybody then say, okay, we specify this in a specific way, that this marginalized subgroup is not going to be affected by this decision. So there are different ways of dealing with this, but just to let you know that when we talk about stakeholder involvement or engagement, because there are all different terms, you might really need to clarify what is meant by that. And in practice, we most often see consultation. I will come back to that. So I like to remind ourselves of the definition of health technology assessment. This is indeed the aspiration that we do have. And Joyce had a very nice slide this morning about the different perspectives, and also the potential views that these different stakeholders might have on the value of technology. You listed the ones with the pictograms. You had the clinician, the patient, the health system, Ministry of Health. And I would like to ask you as the audience also to think about this a bit. It's more how you would think when you, for example, would have to decide on a certain reimbursement of a new treatment. In this case, it's a simplified, of course, example. So here we have a standard treatment compared to a new treatment, and the new treatment is, in terms of effectiveness, a bit better, 5% better than the old one, and also cost, a bit more. So the question is, if you would be a patient, which treatment would you choose? Who would go for treatment A, say the standard treatment? Who would go for B? And why would you go for B? Sophia?
The chance of cure is higher, so I'll
Yeah.
go for the B.
Yeah, so you would go for the more effective one, right? Irrespective if it was a bit expensive. You don't care about that.
Yeah.
Yeah,
I don't.
and I think that was also mentioned then this morning as well, that the patient often tend to focus on the effective. Fair enough, this is a very valid viewpoint, and there is no right or no wrong. But now, when you would be the decision maker, what would you reimburse? Would you also go for treatment B? Anna Carolina, what would you say?
No, I
No.
wouldn't.
And why would you say no?
Because the cost is lower overall, and the cure don't seem too different from option B.
Yeah, so you don't think the 5% is worth the $20,000 US,
Yeah.
right?
Yes.
Yeah, so these are exactly things that happen in practice as well, right? I mean, it's a very simplified example, but it clearly shows that different stakeholders might have different perspectives, right? And if you would not know this, it makes it harder to also have the deliberation about this. So it's also the question why is very important. Okay? So just to let you think about this a bit. So therefore, it's also very important when we talk about health technology assessment that it's very important to understand how we came to this evidence, right? So, and this is why scoping is so important in health technology assessment. It's the first phase of doing an assessment. So it's actually defining your PICO, your research question. So once you have a policy problem, for example, do we need to reimburse, I don't know, multiple myeloma in Brazil, you need to translate this in a research question, right? So you need to define which population is eligible for indeed maybe the new drugs. Are these the ones, the patients that are not eligible anymore for stem cell transplantation? We have seen many examples of that yesterday. And which drugs then are available, and what are the new ones, for example, what are the comparators here, but also what are relevant outcomes here. And I think we also have heard also yesterday, but also this morning, indeed, that it depends on who you ask what are relevant outcome measures. And we tend to focus on, I think also yesterday it was clearly shown, that we tend to focus on outcome measures, clinical related outcome measures like mortality figures. We saw overall survival. We saw surrogate measures like progression-free survival, for example, yesterday mentioned. But I didn't see any quality of life endpoints, for example, mentioned. And this is potentially also, depending on who you ask, what a relevant outcome measure in this particular health technology assessment is. Because if you would ask a patient, you would potentially have other outcome measures than if you would ask the clinician, right? So it's very important to ask in a scoping from what actually are here the key problems that we are trying to solve. From which perspective also are we trying to look at this technology, and also how potentially could this technology solve the problem that is at hand. And this is an example that I studied quite extensively myself with the group I'm working in. It's non-invasive prenatal testing. You're potentially all aware of this. And the question that I would like to ask you is, and this is maybe not completely new, but it's fairly new. It is used now. But the question is, of course, what kind of key problems are we trying to solve with this new technology? Who would like to reflect on this? Why are we introducing this new technology? Or potentially, what is the problem at hand compared to the existing prenatal screening methods? And this is a simple blood test, so nobody dares to, maybe Maria. You know, I'm like a teacher. I'm now pinpointing to people, which I don't like, but it's in your field of expertise. So
prenatal testing, especially in the first 3 months, you're looking for malformations mainly. It's a big objective, and those different methods have different sensitivity, specificity, and risk.
yes,
So you have to take them in consideration, and how often they are used, you know, and what infrastructure you have for those. But in principle, always non-invasive technologies are always attractive.
yes. So that's a very good
except
answer.
for ultrasound, the other two are invasive. So
Yeah. Yeah. So I agree with you that this could be potentially an answer. I mean, that's your answer, right? From your clinical perspective and your experience. But there might be different views on what makes NIPT, that's the abbreviation, desirable. Because you were talking indeed about detecting genetic abnormalities. And from your perspective, this is a very important outcome, I mean, or goal actually, for why we want to introduce NIPT in the healthcare system. And maybe also to prevent the birth of a child with genetic abnormalities. This is particularly for detecting, for example, children that potentially might have the syndrome of Down. So there's the few trisomies that you can detect with the NIPT. But for example, when you are a patient, you might also have a different viewpoint, that you would like to have a more facilitated, informed choice, whether or not to do an abortion, for example. That is not necessarily anything to do with the detection of abnormalities, but more, okay, I want to make an informed choice because I have the autonomy to have the right to know, I have the maternal autonomy of my own body to decide whatever I want, irrespective of the outcome. So that could be a different viewpoint, that if you would not ask a patient, you would not know. We only would ask Maria, because she is the professor, and she would be leading this HTA. We might have missed important outcome measures. So that's a very important point I want to make here. And on the right side of this slide, you can see, this is coming from policy theory, is indeed, in order to have a feel for how well-structured policy problems are, is that you have to have a feel for if there is any potential disagreement on indeed, what is the aim of this technology. And so is there any agreement on potentially what we are trying to achieve with this technology or trying to avoid. And I gave you the example yesterday of the cochlear implants, that there might be completely opposite views that potentially can also have an impact on the effectiveness of using the technology in practice. So this is, I think, very important. So it's about, first of all, trying to understand, have we captured all viewpoints clearly in the scoping of this problem? That's the first one. And then the second one, and Maria already alluded to this, is indeed, what kind of evidence do we need in order to answer the question? And Maria already alluded to that. You say, oh, we need to know something about the sensitivity and the specificity, which is very important. And indeed, it depends, the relevant facts also depends indeed on how you determine your desirable and undesirable outcomes. And so then, once you know that, you need to define your outcomes. And yeah, like I said, Maria already said something about detecting genetic abnormalities, and she said clearly, I said to you, that's the clinical perspective, focusing on effectiveness. And she also alluded that in order to say something about it, we need to know the sensitivity and the specificity, maybe also the positive predictive value. But if you would be the patient and you would like to, or the mother or the partner of the mother, would like to have a feel for informed choice, you might also want to collect different kinds of data. And so you might want to have more qualitative data on experiences, for example, of patients, how well they were informed. You would like to, maybe to know more about the quality of life of patients that went through such a procedure. So you have to collect different types of data. So this is also why it's so important to know the different viewpoints of different stakeholders in the scoping, okay? So that's why stakeholder participation is very important. So it's not only one dominant view in order to say something about the potential value of this technology. Oh yes, of course. This is very interactive. I like this.
It's something I worked on in the end of the 90s because...
Maybe in Portuguese, then
Huh?
You can go in Portuguese.
Oh, yeah. É uma coisa que eu estudo.
It's something I've been working at the end of the 90s. I've got an article. Is that the door was opened. Sometimes we don't notice that some technologies, the ultrasound opened a door to visualize the fetus. In Brazil, this has had an effect because abortion is prohibited in Brazil unless you have a mother risk or harassment or rape. There has not been prediction for malformation at that time. And the diffusion of the ultrasound and the desire of the mothers to have the ultrasound as a signal of good prenatal follow-up, the adhesion to this technology has generated a huge problem. There was a cycle at that time of this ultrasound effect and the role of the press. Because the argument was that you cannot have because the fetus is alive. And at that time, the press was important to say, oh no, there was science behind it. So it's needed to take scientific knowledge in consideration. We have to accept this scientific knowledge. So after some struggle, we've introduced the abortion in case of malformation that had lethal risk. This is very interesting.
Of course, I was aware of indeed, but I forgot about this indeed, that abortion is forbidden in Brazil. And that's also why context is so important, actually, because, I mean, in the Netherlands, I mean, we have the right to abortion. So it's a completely different context, and that's also why scoping is so important, as well as in trying to elicit these views, and from which views, whether or not they are related to some cultural or religious perspective. That's also very important to know. So thank you for that. Yeah, and I'm already thinking about other things in this case. But yeah, I think this really makes the case that scoping is fundamental for an assessment. So what is a relevant question in the Netherlands not necessarily might be a relevant question, research question in Brazil. That's clearly what makes it explicit, this discussion that we had. So when we talk about scoping and assessment, you can also have different stakeholders involved in your scoping and in your assessment. Specifically, indeed, I already said so, that patients may be asked about what it is to live with the disease, and for researchers to really understand the nature of this problem from a patient perspective, but also to really understand what from their perspective are relevant outcome measures, or, for example, important side effects, because we also tend to very much focus always on the side effects that are reported by clinicians, but you know, patients might perceive different side effects that are not necessarily always reported. Also, especially when we talk about different diseases, the caregivers might also have a very important role in what are potentially relevant outcome measures, not only for the patient, him or herself, but also the environment. For example, if a person has a neurological disorder that is a chronic disease, it might have a very big impact on the environment of this patient. For example, because this person is very dependent on the relatives, for example. And this is also very important to see how the perspective of caregivers, informal caregivers, can be taken into account in HTA. This is done in some instances, but not in a very standardized way. We already talked about clinical experts. Very important, of course, to have them involved in the scoping, especially to understand the current landscape of treatments, or the treatment pathways, but also to hear especially their views on potentially how this landscape might change in terms of what they know about new innovations that are talked about at scientific conferences, for example. That's very, very important to understand as well. Payers can be asked, it's more consultation and participation, about resource utilization, how often is this new drug already used, or off-label use, or whatever, if they have the data. And of course, industry is also very important in this case, because they might be asked to, we might ask them about their PICO design and the design of the evidence package that they need to deliver, because a lot of countries still use the evidence dossier from the industry in order to perform an HTA. The question, of course, is, are they fully considered in HTA? Are stakeholders fully considered? I already alluded a bit about the consultation versus the participation, so I already gave this away, but the question is also, how often are these different stakeholders involved, for example, in scoping or in appraisal? And WHO has done some research on this. This is a questionnaire that they send out every 2 years. It's publicly available if you want to learn more. But it's a quite comprehensive overview. I would say snapshot. Very comprehensive, but not very detailed. But at least give you some feel for how HTA is organized globally. So they work with their focal points in every member state to see if HTA is institutionalized, who are the main stakeholders, but also to what extent different stakeholders are involved. And in this case, for example, HTA topic nomination and selection. So this is very much about the scoping of the research as such, not individually every single technology, but more who determines actually the agenda for HTA in a country. And here you can see that in a lot of countries, the Ministry of Health has, I would say, the voice to determine what is going to be assessed. And here you can definitely see that the public, the civil society and the patient organizations are not yet very much included in the agenda setting for HTA. We more or less see the same for appraisal committees. Here you can clearly see that in a lot of appraisal committees, the dominant view is clinicians. That's what we see, and that's also what we experience ourselves. I also did quite some comparative analysis of different HTA systems around the globe, and that also in this case the patient and the public are not very well represented. I mean, it does not say anything about stakeholder participation as such, but it says something about the representation of different stakeholders in HTA. And the question, of course, is, because we are talking about precision oncology, is this different in precision oncology? Well, I think you already know the answer, and the answer is not really. And so I think we also already discussed this yesterday and today as well, is that the impact on precision oncology on disease outcome is quite really well documented, but that patient-reported outcomes have been included, but not very much published about it. So the real evidence there is quite limited, and there are quite some views on the experience of survivorship and informal care, but these are not yet very much studied. And this is a quote that I took from a very interesting article that I read. And here you can also see that there are different views. For example, I mean, we talked a lot about hope this morning, but patient caregivers, but also clinicians, are reframing hope in the precision oncology context. And this is because this field is so dynamic. So this is also something to really understand. So how actually can views on disease, concepts of disease and health change over time? And how would that potentially impact, for example, also the outcome measures that you use in HTA? So the question you could ask yourself is, do we need to indeed focus more in this dynamic fields on reassessments after certain years, because this field is so dynamic? This is a question I maybe also have for the Conitec. If you do have a view on this, or do you have a certain policy with regards to reassessment? And there are some countries that have a policy that says that you need to do a reassessment after every 5 years. But the question, of course, is that needed for every single field, because some of the fields might be more stable than others, and is 5 year long or is this short? And how does that relate also, for example, to your recommendations, your recommendations with regard to, for example, performance-based agreements or financial negotiations? So how is reassessment and also the dynamics around the viewpoints on outcome measures included in those? So these are the questions I have myself. And very important is also this last part of this quote, which I like, is indeed also, do we really understand each other in terms of, do we really have a common language about how we perceive the evidence in this respect? So, and that's, I think, also the first speaker this morning spoke about this. It's very important that we also train stakeholders that are not so well known about all the jargon that we use. We use a lot of terms that we perceive very common, but that's not very common for people who are new to the field or would like to have an equal discussion about certain facts and evidence that is on the table. And I can assure you that, you know, the HTA report that an appraisal committee receives is full of technical details, not only about, you know, clinical words, but also about statistics that are, for example, used in order to determine the evidence. And the interpretation, for example, of confidence intervals are not for granted for everybody, right? So if you have patient representatives at your table, I mean, do we really know that they understand the evidence that we are talking about? So this is also very important to know. So do we really, I mean, who is an expert, and who is at the table, but also is everybody at the table well informed and well capable of elicit their views in terms of interpreting the evidence that we need to appraise. And this, I think, has not been well researched either, and I think this is fundamental in order to have good deliberations with everybody that is making these very important recommendations, as well as assessment. So in assessment we need to do critical appraisal, but I think it would be good to also see how well, you know, the decisions were made, how well the process was done, and also how, that we really know that this is the way forward, because the bigger the groups are in terms of appraisal committees, the potentially also more difficult it is to weigh the potential different viewpoints in order to come to an informed decision. So I think this is very important as well. This is more or less to conclude. I mean, there is quite consensus in the HTA community nowadays that patient and public involvement is vital for HTA, and we perceive that when this is missing, it's a fatal flaw in the evidence collection of the HTA, so this is very important. The pace, however, in terms of the participation, in terms of collecting patient-based evidence, is slow, so it's not fully embedded yet in several countries, so it's still we still have a way to go, I would say. Also, and I think a lot of you already alluded to this, progress in patient and public involvement is not equally around the globe, and there are some countries that are quite at the forefront. You also mentioned this morning that in Brazil it can be better. So yeah, I think there's still a lot to be done. And we need to work together also to make this happen. And I think that's why I'm so happy with this resolution of WHO to say that social participation is the way to go for striving for universal healthcare coverage. So I'm quite confident that there also will be more resources available for that. There is some guidance available for stakeholder participation or deliberation. There is a very nice book, and I know that they are working on a second edition that will be published next year. It's the patient involvement in HTA, done by colleagues from the interest group on patient and citizens involvement from the International Society for Health Technology Assessment, so HTI. It's led by Karen Facey. There's also some guidance on social participation published by WHO. That's mainly focusing on governments, so not necessarily on HTA bodies, but mainly on indeed how can we involve public in deliberations about questions that are at the societal level. For example, you could think about organizing public debates around I don't know, the use of evidence in policy making, for example, but you can also use this for HTA. And then there's some guidance that I co-led about deliberative processes in HTA processes that was also published a few years ago. This is used by some of the countries to see how well they are actually doing deliberation, and it gives some guidance on all the aspects that I mentioned. So what is the aim of the deliberation? What are we trying to achieve? Is it a consensus or not? How do you select stakeholders? How do you engage stakeholders? What kind of resources do you need for stakeholder participation? how do you monitor and evaluate the impact of stakeholder participation? So there is some guidance around this that you might want to look at and see how applicable it is to your own context. And with regard to normative analysis in HTA, which I alluded to yesterday, there is a handbook available. This is more about, indeed, integrating the LC that Patricia was talking about this morning. It's free downloadable from this website, so it's free of charge. So if you are interested in more having a feel for the things that I talked about, how can you elicit the views of different stakeholders in your HTA, you know, then you might want to look at this. So that's what I would like to talk about. Thank you so much, Patricia, for inviting me to this, you know, eminent audience. I really enjoyed the discussion this morning, and I hope that we can discuss a bit more. Thank you.
Nós é que agradecemos.
We thank you. Your lecture and every lecture here, they were excellent. The insights we had, the food for thought, it were provided for us. Paying attention to your last contribution, I was thinking on the challenge. These reassessments will be considering the technology life cycle entirely, not only talking about methods, but also number of people involved, data platforms we need to develop, methodology of studies itself. It needs to be adjusted, some methodology will need to be developed, especially when we discussed today. I mean, even the social participation is so important. We need to have people's voice. But when we need the voice really to be heard and incorporated in these decision-making processes, we should not only open space for patients' point of view, but when we see the results of deliberative processes, we see the voices weren't heard. So it goes much beyond than opening spaces. We need to qualify the social participation as well. And how can we qualify and re-qualify these people along the reassessments, along this life cycle? These are differentiated moments from the development of the new products, new technologies, up to the end of this cycle, when we are having reassessments and we are going to say, this hasn't been effective, we are going to remove this technology for the health system. So there's a problem at this time. And I have been thinking, if this assessment along the cycle, how can we include social participation in a qualified manner? And how can we ensure they will keep aligned with the HTA, even when the results will not be what we expected? In the case of removing the technologies from the health system, normally this is not seen in a good manner. All these matters are so interesting. How can we include it in the processes of assessment and deliberative processes of our unified health system in Brazil? Now I'll open for questions, and afterwards we'll comment a bit more. Actually, it's not a question. It's a comment, so we can consider something. From January, European Union will have a new method, systematic of working for the state members when assessing technologies. It's something additional to pay attention to this scenario that Professor brought to us.
Well, because it's, I mean, only in the European Union, we do have now a law on health technology assessment. It's called HTA regulation. And it is meant to be mandatory, but only for doing joint assessments. So all the 27 member states need to align on the assessment of relative effectiveness. So it's not focusing on cost effectiveness or other dimensions, but only on the relative effectiveness, and it will be implemented in terms of staggered. We first start with oncology drugs. Joyce knows all about it because industry needs to adhere to this as well, but also the HTA bodies need to work on a common PICO, for example, for focusing on the relative effectiveness, and they are now in the midst of producing all guidance, for example, how to deal with indirect treatments, how to deal with I don't know, the PICO, how to define the PICO there. So if you are interested in this, these are all publicly available on the website of the European Commission. But just to note, it's only one small component of the HTA, and so the idea is that from this joint clinical assessment, we call it, it is mandatory for the member state to take that into consideration in their HTA, but they might want to include other elements, for example, quality of life or other effectiveness measures that are not part of this relative effectiveness. Just so it's only one small component. Also very important to note that there is also one part of the regulation is focusing on joint scientific consultation, which is much earlier in the life cycle. So in this case, the regulatory agency, so EMA, has to work closely with the HTA bodies in order to see what are the evidentiary requirements from a regulatory perspective and how they can align this with the evidentiary requirements for HTA. So it's aligning the processes for the 27 member states that we do have from the early phases onwards, for all new products that are coming to the market. And from 2028 onwards, it's for everything, but now they are staggering. So oncology first, then high-risk medical devices and ATMPs, and then from 2028 onwards, all new substance. Thank you.
Let me comment on something else about the reassessment, the experiences we have had. In this point, the non-aligned, the ones that are not aligned, they disappear. All the experiences we've had were not successful. In the cases of reassessment, where evidence would say, do not change this product or device. And they feel as if they are losing their rights. People disagree, only the HTA body tries to prove, and evidence is never robust enough to justify removing it. Now, from this point of view, it's clearer to see the need of collaboration from the start. If we get the result at the end and want the allies, it's not going to work. They need to be involved from the start. So this is lessons learned I have now. Even if we do not have this collaboration from the start, social participation is not going on, we have margins of improvements, maybe in a specific process. In reassessment, this may be a way to work in parallel, to work this precocious collaboration, this incipient maybe collaboration, and have this involvement, not only communication or consultations.
Can I just ask something, because Patricia, you reminded me of, indeed, how can we include social participation in the discussion, that in the Netherlands we have currently, huge debates about what we call societal acceptable prices for for drugs, especially the high-priced drugs. So the Ministry of Health is now working with the health insurers and with the authority that sets the tariffs for the prices, together with the collaboration with the HTA body, to see how they can have a public discussion about what the Netherlands population perceives to be societal acceptable expenses on drugs. So, and there are different elements included in this, I would say, approach. So, one thing is indeed how can we technically, in the HTA process, see how we can tackle this. What is a societal acceptable price? Because, yeah, we do have the cost per quality related to the disease burden, but that's not an acceptable social price. That is just, a threshold for the cost per quality related to so that not necessarily has to be a social acceptable price. But in addition to the technicalities, to see what methods we potentially are going to use, for example, to determine the disease burden. There are different methods for doing this, so proportional shortfall and fair innings, and these are all ethical frameworks. So how do you deal with, for example, the use of age in determining your disease burden? There is another activity that is indeed trying to, or not trying, they will, organize a public discussion with citizens of the Netherlands. So this will be research, and actually this will be done by my university, not necessarily by myself, but with people I know. They will organize public consultations or weekends with citizens that are pulled from a representative sample, and they will discuss cases in order to elicit the preferences of the Dutch populations with regard to what is to be perceived as a social acceptable price, based of course on also literature that will be used to organize these focus groups, you could say these focus groups. But I was wondering, would something like this be possible in Brazil as well? And to have social participation, to see what are the preferences of the society with regard to what do we as a society perceive to be acceptable that we pay, because then you might also, if you can make it clear to the public that this is a very important point and you want to elicit their views and what is acceptable from their perspective, of course knowing what the boundaries will be, either you pay it out of pocket or via your insurance premium, which needs to be very clear. Would that be something that you have considered, or would it be possible? I was just curious about this.
Por coincidência, acho que semana passada.
Last week I read an article where they classify medicine price and they create many categories. What's acceptable, what's not acceptable. So there are many categories. I was imagining how we would use it in Brazil to discuss with the population. I don't know. Carol is nodding. I do not know any activities on that regard, on this broader discussion with society. Even the cost-effectiveness threshold, this is more recent. Maybe it was a discussion in the HTA body and not with society as a whole, determine this value, I mean. I do not know any moves in that regard. Here, price is defined after medication being certified by Anvisa. There's an institution, CEMED, responsible for pricing this medicine, and then there are analysts that assess this. And this is done in a different moment, is not connecting to an AGTA national body. This would be an incredible discussion. Carol can foster this discussion with social participation, and we will be aligned. Let's see who are our allies, who will collaborate on this debate. Any other question? I think we are wrapping up. I would like to invite Claudia to come here so that we can wrap our event up.
And thank one more time for your acceptance to this invitation and all the insights you have brought. We hope this is going to be a long-term collaboration with our group and other groups in Brazil. Thank you so much for your participation here.
Então, acho que
So, wrapping up this first opening event, we'd like to remind you that this has been conducted by our research group, the IEA-USP. And I would like you to know that this is the first debate from other one that we are going to conduct. The other ones are going to be more in workshop format. We are going to call stakeholders in groups. And I would like you to remind you that discussing the assessment to health from the perspective of equity, efficiency, sustainability of SUS is our objective. And you are all welcome to participate in the group. You have our email, so feel free to keep in touch and think on how we can collaborate over the next events. I would like to thank especially the Deliberative Council of DAA in the person of Roseli Lopes, Professor Aritonsk, who is the previous dean that has always stimulated and collaborated since the time we had this study group that was coordinated by Maria. All IEA group, Marlene and all the team, and all the DEAM office group, the preventive medical service group from the post-graduation in collective health. This organization organizes 2 programs of post-graduation. We have another one that is a master's degree in innovation that belongs to the faculty of the medical school of USP. So it's an event that has been organized by the 2 post-graduation programs, actually. I would like to thank for your presence, those who are present and those who are following us in the channel, almost 400 people. A percentage of them is listening in English. I don't know where they come from, but they are listening to us in English. I was really glad with this first event. I would like to count on you for the next events, and I would like to give the floor to Claudia. I would like to thank you all, those who are out of here. The email is eetop@usp.br. This is a contact detail that you have with us. We're going to have the kickoff meeting of the project. The group has been just approved by the council, so we haven't had yet the kickoff meeting. And after that, we're going to have an agenda that we are going to let you know. We are going to have a web page as well. And on the from usp.br website, you can see the people and you can see the agenda. So this is a way for you to have access to what we've been doing. And thank you all to this institute, to the team, our sponsors. You are essential for us in sponsoring, communication, partnership, C2PO as well, and all of you who are here or at home, at your offices, online. Thank you so much.